In this last lecture, we'll look at the regulation of ultrasound equipment and its use, and policies and guidelines that you can find to help you use it appropriately. An important element, of course, is government regulation. In 1976, in the US, the Food and Drug Administration was given responsibility for regulating both the use and the manufacture of ultrasound equipment. Because there was not sufficient scientific basis for determining safe exposure levels, they took a totally pragmatic approach. They said since there had been no recorded cases where patients had been harmed by exposure to ultrasound, that they would deem the output levels for all the equipment used until that time to be safe. So they did a survey and they established a database of the output levels for all the different machines and used that to set safe upper limits for the exposure for 4 different clinical areas: ophthalmic, cardiac, vascular, and general ultrasound. These are referred to as the pre-1976 limits. And in fact, it is still possible today for manufacturers to register equipment under those old limits. However, in the 1990s, it was determined that there was now a good scientific basis for determining operating levels, and in particular, based on the introduction of the thermal index and the mechanical index, which I've described. So you will remember that the purpose of the TI and the MI is to indicate to the user what the exposure levels are in meaningful terms relating to the safety of the exposure. So the TI tells you what the expected maximum temperature rise in the patient's tissues will be, and the MI tells you whether or not it is likely that there could be cavitation. And the reason for these being displayed is that it is now, under the new regulations, the user's responsibility to monitor the exposure levels and determine if they're safe. One of the consequences of this new approach is that modern machines can transmit significantly higher power levels than the machines dating back to the pre-1976 standard. So modern equipment is more powerful. One of the clinical needs driving that is the increasing obesity of the population. I have spoken about the US and the FDA because they were the first to move on this issue. However, as you would expect, now there is regulation in place in every country and geographic area, and these tend to be very, very similar to the rules that were set up by the FDA. So there's a worldwide consensus on the approach to safety, basing it on the display of the TI and MI, and the idea that it is now the user's responsibility to monitor those indices and use ultrasound safely. Here we have a renal scan showing us a TI value of just 0.2. So that means that the estimated maximum temperature rise due to the exposure is only about 0.2 of a degree. Mechanical index, on the other hand, is relatively high. On the right, we have a Doppler image, and you can see that we have a significantly higher TI, and you'll notice now that the TIB is being used because there is now soft tissue bone in the area of interest. So quite different pattern depending upon the settings of the machine, the application, etc. An important question, of course, is how do you, the user, know what are safe limits for the thermal index and the mechanical index? What I'm showing here is data prepared by the British Medical Ultrasound Society and published in their guidelines. Other organisations around the world, professional and international organisations, publish similar guidelines with pretty much the same sort of information in them. So let's take a look. On the left, we have a table extracted from that document. These tables are taken from my textbook, but the data is extracted from the BMUS document. And what you can see is that for obstetric scanning and neonatal transcranial and spinal scanning, there are no limits on the scan time if the TI is less than 0.7. If it's below 1, then they recommend a maximum time of 60 minutes. If it's less than 1.5, then 30 minutes, and so on. As the TI gets higher, they recommend shorter and shorter scanning times. Here we have a table that relates to adult transcranial scanning, and you can see quite similar figures. On the right, we have yet another table that relates to all other clinical areas other than ophthalmology. Now you'll see that the TI values can be higher before any limits are recommended at all, and those limits are then fairly generous up until a TI value of about 2. This table also suggests that it's okay to use quite high TI values, if necessary, for very brief periods of time. What about the MI? Well, this is a little different. And the first thing to say is that the regulation of the manufacturers by the Food and Drug Administration and similar bodies in other countries says that the machines must not be able to exceed an MI value of 1.9. That value of 1.9 used to be regarded as the threshold below which cavitation could not occur. Now there is more information available, and so we need to look at what this British Medical Ultrasound Society document says about MI values. So probably the single most important thing is that it says for an MI value above 0.7, there is a risk of cavitation if an ultrasound contrast agent containing gas microspheres is being used. We'll see in a subsequent lecture that ultrasound contrast agents normally consist of tiny bubbles of gas. So what this is saying is that if you're using those contrast agents, you should be very careful not to use MI values above 0.7. They go on to say there is also, at least theoretically, a risk of cavitation even without the use of contrast agents, so presumably due to gas bubbles that are present in the patient for other reasons. And therefore the implication is you would much prefer to be using MI values below 0.7 as far as possible. The final statement that they make is that as the MI increases, the risk of cavitation increases as well. So we've addressed the fairly narrow question of what are the limits on the TI and MI and how do we know what are the safe limits. But now let's look more broadly. All of these different organisations around the world, the British Medical Ultrasound Society, the American Institute for Ultrasound in Medicine, the World Federation for Ultrasound in Medicine Biology, Australian Society for Ultrasound in Medicine, all of these bodies have quite similar policies. The policies state, as I mentioned earlier, that there are no documented cases of patients being harmed by diagnostic ultrasound. But the documents then go on to talk about the precautionary principle. One of the main ways that this is put into effect is through the well-known ALARA principle, which is widely known in radiology. So this, of course, stands for as low as reasonably achievable. And the idea is that both exposure levels and the amount of time of the exposure should be kept as low as reasonably achievable. The wording of this, of course, has been carefully chosen to emphasize the fact that you shouldn't compromise the quality of the examination in order to minimize the exposure levels. So it's very important that you remember that ultrasound is very likely to be completely safe and that your primary goal is to get diagnostic information. One other way in which the precautionary principle is applied is the policy which is very widely adopted, which says that patients and other people should only be scanned when there's a medical indication. So in other words, when there's likely to be a benefit to the patient. And then there is an exception to this, which says that it is also appropriate for research and education purposes. So, in summary, ultrasound has an excellent safety record, but we should use it appropriately and we should follow the ALARA principle. Professional organisations around the world give you guidance regarding the safe limits for the thermal index and the mechanical index and the appropriate scan times for different application areas. And there are other principles, such as the one I've just discussed, about scanning patients only when medically indicated. So this basically is the framework for the safe use of ultrasound.